Welcome to The Explainer. Today, we're diving into a topic that is, let's be real, guaranteed to pop up on your exams: lung cancer. We're going to build a rock solid framework so you can move beyond just memorizing facts and really tackle any clinical scenario they throw at you with confidence.
Okay, so picture this. You're in your oral boards, and they hit you with this classic prompt: a suspicious mass on a chest x-ray. The key here isn't just rattling off a list of facts. It's about showing the examiner how you think, your clinical reasoning. So let's break down exactly how to build that perfect, systematic answer.
So here's our game plan. We'll start with the foundations, the classification and genetics. Then we'll walk through the workup, from diagnosis to staging. After that, we'll connect it all to the treatment plan. And we'll finish up with some high-yield clinical pearls that are absolute gold for exam day. Okay, first up, let's lay the groundwork. You've got to get the fundamental classification right, because honestly, everything else we talk about today is going to hinge on this. It dictates the prognosis, the treatment, the whole shebang.
At the highest level, it really all boils down to this simple but incredibly important split. About 3/4 of the time, we're talking about non-small cell lung cancer. That other quarter, that's small cell. And as you're about to see, they are two completely different animals. So, what's the real difference here? Well, think of small cell as the fast and furious version. It's usually central, it grows like crazy, and it spreads early. Now, it's pretty sensitive to chemo at first, but the long-term prognosis, well, it's generally poor. Non-small cell, on the other hand, is a bit of a different beast. You've got adenocarcinoma, often on the periphery, and squamous cell, which is more central. The game plan here is usually surgery or these new targeted therapies.
But, histology is really just the beginning of the story these days. The paradigm has totally shifted. Now, especially for non-small cell, it's all about the molecular drivers. We have to figure out the specific genetic mutation that's actually fueling the cancer. And this table, wow, this is basically the cheat sheet for modern lung cancer treatment. Don't just try to memorize this list. Think of it like a menu, right? You find the mutation, you pick the drug. You find an EGFR mutation, boom, you use osimertinib. An LK translocation, that means you're reaching for alectinib. This idea, matching the drug to the specific mutation, is an absolutely critical, high-yield concept. All right, so we've got the basics down. Now let's talk about the workup. How do you actually take that suspicious spot on an X-ray and figure out what's really going on? How do you put these foundational concepts into practice?
You want to walk the examiner through this step by step. It's a logical flow. You start with the chest X-ray, where you first spotted it. Then you get a much better look with a high-res CT scan to really characterize the mass. Next, a PET CT to see if it's gone anywhere else. But the final word, the definitive answer, comes from the biopsy. You've heard it before, tissue is the issue. For a central lesion, you'll go in with a bronchoscope. For a peripheral one, a CT-guided biopsy is the way to go. Okay, so you've got your diagnosis. What's next? Staging. And let me tell you, staging is everything. It's not just some academic exercise. It's the single biggest factor that determines prognosis and the entire treatment plan. And the gold standard for that? The TNM system. So let's break TNM down, starting with the T for tumor. This is pretty straightforward. It's all about the size of the primary tumor and whether it's starting to invade its neighbors. Is it a tiny little T1 all contained, or is it a big T4 that's growing into critical stuff like the heart or the great vessels? Next up, N for nodes, and this one is a huge predictor of how things are going to go. N0, no nodes involved. Great news. N1 means it's in the nearby nodes on the same side. N2, it's moved to the mediastinum on the same side. And N3, the worst prognosis, means it's crossed over to the other side or gone up to the clavicle. And wow, just look at this chart. This is why end staging is so critical. Look at that cliff edge drop in 5-year survival as you go from N0 to N3. An N0 diagnosis has a decent shot at a cure, but by the time you hit N3, survival is less than 5%. That is a point you absolutely want to hammer home in your exam. And rounding it out, we've got M for metastasis. This one's pretty black and white. M0 means it hasn't spread. Any kind of M1 designation, whether it's in the other lung, a single spot somewhere else, or multiple spots, you're automatically dealing with stage 4 disease. Okay, so we've done all that hard work of diagnosing and staging. Now for the payoff. What do we do about it? Let's connect the staging directly to the treatment plan and see how it all comes together.
This table really lays it all out pretty clearly. For the early stages, I and II, we're thinking cure, and that means surgery. A lobectomy is the go-to. When you get to stage 3A, things get a bit more complicated. Often you'll hit it with chemo first to try and shrink it down before surgery. And by stage 4, well, surgery's off the table for a cure. So we switch gears to systemic therapy, chemo, targeted drugs, or immunotherapy. So what if you run the molecular panel and nothing? No targetable mutation. What then? Well, this is where immunotherapy has been an absolute game changer. For these patients, especially if their tumor expresses a lot of PD-L1, we use drugs called checkpoint inhibitors. Think of them as taking the brakes off your body's own immune system, letting your T cells see and attack the cancer. It's a frontline standard of care now. All right, buckle up. Now we're getting into the rapid fire section. These are those high-yield pearls, the special cases, and classic syndromes that examiners love to throw at you. These are the details that can take your answer from good to great. Let's lock them in. You can bet you'll get a question on paraneoplastic syndromes, so you need to know these cold. The trick is to link the syndrome to the right type of cancer. For small cell, think of it as the hormone crazy one. It pumps out stuff that causes Lambert-Eaton, SIADH with low sodium, or Cushing's from ectotic ACTH. For non-small cell, especially squamous cell, the classic association is hypercalcemia, caused by the tumor making a PTH-related peptide. Okay, here's a classic case for you. A patient walks in with right shoulder pain, and it's shooting down their arm. You also notice they have a droopy eyelid and a tiny constricted pupil on that same side. What is screaming out at you? And the answer is a Pancoast tumor that's causing Horner's syndrome. It makes perfect sense when you think about the anatomy, right? The tumor's at the very top, the apex of the lung. So as it grows, it can press on the brachial plexus, that's your arm pain. And if it also hits the sympathetic nerves running nearby, it gives you that classic triad for Horner's, the ptosis, meiosis, and anhidrosis. Recognizing that combo is key. All right, let's boil this all down to the absolute must-know takeaways. 1. Classify. Is it small cell or non-small cell? Then, for non-small cell, find that driver mutation. 2. Stage. TNM is king. It drives everything that follows. 3. Treat. Match the drug to the mutation or use immunotherapy if there's no target. And 4. Recognize the classics. Know your paraneoplastic syndromes and what a Pancoast tumor looks like.
And I'll leave you with this to chew on. For decades, the TNM system, which is basically an anatomical map of the cancer, has been our primary guide. But as we get better and better at treating the specific biology of a tumor with these targeted drugs, does the anatomy matter as much? Is a tiny tumor with a really nasty mutation actually worse than a bigger, slower growing one? That's really the question shaping the entire future of oncology.